Good afternoon. As Khadija mentioned that this would be a case study, and it's a successful case study from Bangladesh. I feel proud on standing on behalf of the government as well as the other partners working on the prevention of postpartum hemorrhage. You can see on the first slide that the names of the two government directors who are responsible for the prevention and management of postpartum hemorrhage, overall maternal health, their name is there. I would have one slide on the approach, and then I would talk about the two prongs of the prevention of the postpartum hemorrhage, the two prongs being one for the facilities and the other one for the community. The PPH prevention approaches, that's the government approach. The government, actually, the first two bullet points, it mentions about that the government has put a lot of emphasis on preventing maternal mortalities. And as such, the community-based skilled birth attendants, having on the side of the women those who are delivering at the homes. So that's a key approach, and which is government is promoting. And for that also, in that connection also, the creation of the midwifery cadre for helping out the deliveries in the facility, that's also a major emphasis given by the government. In addition, the government has been, trying out different kinds of interventions. One is the demand side financing. They are now in the process of scaling it up in the recently started health population nutrition sector development program. So DSF is the name of that, the acronym of that. There are other community level interventions besides PPH. Government is putting an equal attention towards pre-eclampsia and eclampsia, and as such, efforts are underway to introduce at the lowest level the magnesium sulfate as a loading dose for the prevention of pre-eclampsia. And as I said earlier, that the two prongs of the PPH prevention, as has been proposed and as has been acted upon by the government, is basically the active management of the third stage of labor for the facilities, and then the community-based distribution and use of Misoprostol. The active management, I will first talk a little bit about the active management of the third stage of labor. There had been a lot of discussion today about this one. We still, in Bangladesh, are following the 3 steps of the active management of the third stage of labor. Back in 2008, we did a national survey, and this was a survey where there were 551 deliveries were observed by paramedics over a period of 2.5 months, and that's the result. The knowledge about the use of uterotonics is very high, but if you go down the ladder, on the 7th step, the 7th bar, that's the actual practice of the AMTSL. That's only 16%, and this 16% includes the doctors, the gynecologists, and the paramedics, the nurses, everyone. So everyone knows about it, but they don't practice it. So after that, there were several interventions were undertaken, some policy guidelines were sent out, but training was one of the major things that was undertaken, and we actually facilitated in developing curriculum and undertaking TOTs and doing the training of the providers. So we started with 25 of the 64 districts, and so these were all within the leadership and under the partnership of the Director General of Health Services and the Director General of Family Planning. We have 2 wings of the Ministry of Health and Family Welfare. We emphasize that the training is not the answer. The supervision and the coaching, on-site coaching, is a very key element, because we have seen in the past that training has been provided, but when the actual practice, we go and see the actual practice, it is not happening, as there had been no supervision. So the supervision had been a key element. We started collecting the practices of the AMTSL. And then what we saw that from the 16%, the practices went up to, in different facilities, up to 85%. In several of the facilities which were monitored very closely, we saw that there had been a reduction of the in-facility postpartum hemorrhage by almost 75%. I work in a project called the Mayar-Hashi, the Smiling Mother's Face. So through that project, we are still continuing to provide the technical assistance to DGHS and DGFP. The challenges which we have faced and are still facing in connection with the AMTSL, it's talking of the implementation experiences. Ensuring countrywide training and supervision. The training is not a very difficult training course. It's very simple, but the supervision is the much more difficult element. And supervision is said to be the weakest system in our health program, in our health and family planning nutrition program. The correct and consistent use of AMTSL, as you have seen in the 2008 assessment, many of the providers, most of the providers, they have the knowledge. But when it comes to the actual practice of those 3 steps, the last 2 steps, they don't practice. So the consistent practicing of all the 3 steps is a big challenge. The cold chain, the maintenance of the cold chain for oxytocin. In the 2008 assessment, we did some key informant interviews, and many of the OBGYNs, they said that the oxytocin ampoules, they give 1 ampoule of oxytocin, still it doesn't work, and then they give 2, and then they give 3, and at the end they end up giving the Misoprostol tablet. So they were complaining that probably the oxytocin drug is of poor quality and the manufacturers are not producing good quality product. But in fact, the damage has been occurring due to the improper storage of the oxytocin. The inclusion of AMTSL in the GOB reporting system, that's also a big challenge. They still don't report. There is no reporting system, so that has to be ensured. Overall, the institutional delivery rate is still very low. So even if we hammer more and more over the providers to practice AMTSL, they will not have enough deliveries occurring in the facilities, because at the facilities, the deliveries end up having in C-sections. So limited ability of facilities that offer the 24 hours delivery is also a big issue. I will talk a little bit about the Misoprostol. Misoprostol, as you know, is an iterotonic drug. And this is very inexpensive, very cheap in our country. It's produced by 4 companies. And it's a fairly static drug, a stable drug. And in the field condition, it can stay quite stable. There are a lot of support that this can be used in the community level. And recently in 2011, the Misoprostol has been included in the WHO essential drug list. I would just mention about several of the milestones before I go into the challenges and the experiences gathered. We started working since 2006. There had been a national PPH Prevention Task Force, which is led by the DG Health Services. And in between, a lot of things have happened. Some policies have been developed. In 2008, the first approval was obtained for piloting using the community workers of both the health and the family planning sites. And as such, after that, the dose was also discussed. Earlier today, Dr. Farhana mentioned that we are now using a 400 microgram, that's the 2 tablets. And then it got approved by the National Technical Committee before it started scaling up. And then by September 2010, it was actually included in the Health Population Nutrition Sector Development Program. I will quickly show this slide, which again Nuria has mentioned about that, that there have been two pilots, one in Tangal district and one in the Cox's Bazar district. The issue here that a large number of women, about 32,000 women who delivered at home, they used Misoprostol. The fear of using Misoprostol at the community level is the mistimely using of the tablet. None of these 32,000 women, they actually used it mistimely. And as such, I mean, it can be said that safely this drug can be used at the community level. Although there were 95%, 5% they didn't use the Misoprostol tablet even if they were given. There were several reasons for that. The national scale-up has started based on the findings of the two pilots as well as the other experiences. ICDDRB had done 2 big studies. And so based on all of those things, the national scale-up started. And as I said earlier, that this has been included in the operational plans of both the DG Health and as well as the DG Family Planning. And they have also included the budget to buy the drug. A phase-wise scaling up has started. Since July 2011, 4 districts have started full-scale using of the Misoprostol tablet. In addition to that, 2 districts, I mean, we have 64 districts, so 2 other districts, there the Misoprostol tablet is being introduced through the MCHIP program.